Good afternoon and a warm welcome to everyone, and thank you for joining us here today at our second annual Breathe Change Policy Series. My name is Jessica Buckley and I am the CEO of the Lung Health Foundation. Today's topic is on mobile lung cancer screening, and we have an exciting lineup of speakers. Before we begin today's panel, however, I would like to do a land acknowledgement. The Lung Health Foundation would like to acknowledge its commitment to the recommendations of the Truth and Reconciliation Commission. As an important part of our commitment to reconciliation, we would like to begin by acknowledging that the land on which we stand upon is the traditional territory of the Anishinaabeg Mississaugas of the New Credit First Nation, the Haudenosaunee, and the Huron-Wendat. This land is now home to many Indigenous nations from across Turtle Island, including the Inuit and the Métis. We acknowledge this land because it's important to remind ourselves that we are working on behalf of all Canadians, including Indigenous people who have been and continue to be negatively impacted by Canada's colonial history. It's impossible to have valuable conversations about lung health in this country without connecting these conversations to the harms done to Indigenous communities. To this day, Indigenous peoples in Canada face health disparities and poor lung health outcomes. While we continue to learn, the Lung Health Foundation is committed to doing our part in reducing these health disparities and enhancing the healthcare system to meet the needs of Indigenous communities. We recognize that many of you attending virtually today are working on parcels of land that do not apply to this land acknowledgement, and we invite you to take some time during the meeting or after the meeting to learn about the colonial and treaty history of the land you live and work on, and reflect on the roles that we can all play to ensure that disparities in health can be successfully eliminated. So, why are we here today? And what are we trying to achieve through these policy forums? Through forums like today's session, the Lung Health Foundation continues its leadership as the voice of Canadians to help tackle some of the most urgent and pressing issues facing people living with lung disease and issues that are facing the healthcare system today. The policy forums are pivotal to our foundation's mission work. Each forum provides strategic opportunities to develop creative and actionable solutions on issues of growing concern. And it brings together the thought leaders that you're going to hear from today from the public and private sectors to discuss urgent and emerging issues in health policy. So once again, I would like to say thank you to each of you for taking the time to join us today. So as many of you know, about 70% of lung cancer cases are diagnosed in late stages, stage 3 or stage 4, and there are limited treatment options at these stages and outcomes can be poor. But what if lung cancer could be caught earlier when the treatment is most effective? Today, we will be highlighting barriers such as risk assessment, screening accessibility, and wait times for lung cancer screening that exist today. We'll explore innovative mobile screening models that could complement existing programs in the province of Ontario, and we're going to hear from subject matter experts from other jurisdictions. Let's get started with our programming. But before I do that, this policy forum would not be possible without the support from our sponsors. And I would like to acknowledge them now. Amgen, AstraZeneca, Bristol Myers Squibb, Gilead, Janssen, Merck, Pfizer, and Roche. Thank you very much for your support. Our host for today's event is Lisa Del Giudice. She is the regional primary care lead for the Toronto Regional Cancer Program. And this role involves developing and disseminating guidelines for primary care physicians and developing programs that will improve patient care throughout the cancer journey. She also has clinical experience providing routine primary care as a family physician. Please join me in welcoming Dr. Lisa Del Giudice.
Hello, good afternoon, everyone. Thank you for inviting me to participate in this topic that's been very near and dear to my heart. I'm very pleased to be here, and I'll be facilitating this afternoon's policy forum. We have a packed agenda today, so I'm going to briefly introduce all of our speakers. If you'd like to see their full biographies, we've sent them to you by email, and they'll also be available in the chat as well, but we'll give you a brief introduction to each of our speakers just now. So let's get started with our first speaker introduction. This is Stephen Graper. Stephen is the president and founder of Healthcare Together Limited, a consulting company with a mission to lead innovative healthcare initiatives. Our next speaker is Christopher Deutschmann. He holds a Master's in Arts Science in Chemical Engineering from the University of Waterloo and is the manager for the Clinical and Liquid Biopsy Informatics, Breathomics, and Radiomics for Early Detection of Lung Cancer, otherwise known as the Lung Caliber Program. Our next speaker is Lisa Jackson, and she's from the Oneida of the Thames First Nation. Lisa holds a degree in sociology at King's University College and a harm reduction certificate from York University. Our next speaker is Laura Pipstein. She's the Chief Medical Officer and Staff Physician at Sherburne Health. Laura has practiced family medicine at Sherburne Health for the past 17 years, where she is committed to providing wraparound holistic primary care to marginalized populations. She'll be followed by Melissa Wheeler, and Melissa will be giving us a taped session. She is a graduate from the University of South Florida with a Bachelor of Social Work degree and a Master of Health Administration degree from Ohio University. She has 30 years experience in healthcare with a concentration in oncology and health equity. And she unfortunately cannot join us, as I mentioned, live today, but she has graciously taped and recorded a presentation for us to see today. And finally, we'll have our next speaker, Teresa Tang, who is the co-founder and CEO of 19 to 0, which is a national health nonprofit focused on empowering communities towards safer health behaviors. So without further ado, we are going to start with Stephen Graper and Christopher Deutschmann, who will provide an overview of the work being done in Ontario in relation to the mobile lung screening program, lung cancer screening program, excuse me, in collaboration with the Lung Health Foundation and the University Health Network. Welcome.
Thank you, Lisa. So yes, as a quick introduction, we're going to talk about the concept of a mobile trailer lung cancer screening program. And then you'll learn about two key initiatives that we're working on right now. And then finally, Christopher will then provide you with some global insights on mobile lung cancer screening. And so this illustration is showing on the left-hand side the interaction between a primary care physician, who could be a GP or an NP, and the patient and the screening navigator. And the screening navigator's role will also be to assess for the eligibility for the patient to enroll in the program after meeting the referral criteria. If the patient is eligible, they'd be referred to the mobile unit, where they would have a low-dose CT scan completed with the support of a CT tech. That data would then be transmitted to a centralized provincial radiology hub, where the radiologist would interpret the findings and send a report back to the referring healthcare professional. What I'd like to do, though, is unpack the phrase mobile trailer lung cancer screening program. And when you hear mobile, I want you to think about deployment models. So you could have a fixed model where a unit is sitting beside a hospital or in a large urban area for long periods of time, like multiple years at a time. You could also have a semi-flexible deployment model where the unit travels from one region to the another, maybe staying for like 2 months at a time. And then you can have the ultra-flexible model where this unit is going, for example, on day visits, where imagine you have like a Ford F-150 truck and a towable generator. going into specific communities. And having that towable generator allows for that additional power to be required when there may not be shore power existing. With respect to trailer, these can range from 40 to 48 feet in length. Regardless of the size, they both have their advantages and disadvantages to them, but the important piece is that they have a CT scanner on the truck, and they're able to go into the communities to meet people where they are at. And with respect to lung cancer screening, just as it says, this is about screening. If a patient is found to have some significant nodules and needs additional follow-up, they'd be referred into one of the official lung cancer screening programs. But really, it's about adding capacity to the system. And this is what makes it very important. And if the unit is, for example, beside a hospital, this is where it could help offset any capacity concerns that may be experienced at that site. But it's obviously adding additional capacity by going out into the community. And finally, program. This is thinking about a nothing about us without us approach to designing the program. And overall, there's a significant amount of collaborations and partnerships that are required in order to make it a very successful program. And so that's a quick kind of overview of the concept of a mobile trailer lung cancer screening program. And as I mentioned, we have two very important initiatives going on right now. One is a community engagement program. This is where we are focusing on increasing lung cancer screening awareness while also conducting focus groups to help determine or find additional insights on the best way to design a program that would meet potential user needs. The second initiative that we're doing is building a business case. So we're seeking input from organizations and communities from different regions in Ontario to help develop a business case in their area. So we have a template ready to go. So if you're interested, please reach out to me at stephen.graper@healthcaretogether.ca, and we can discuss this much more. And so now I'll pass it over to Christopher to wrap up the introduction.
Fantastic. Thanks so much, Steve. So I'm just going to briefly talk about some of the highlights from the World Conference on Lung Cancer CT Screening Symposium that happened just over a month ago. So the CT Screening Symposium was a full-day event preceding the World Conference on Lung Cancer this year. There was quite a few different topics, but the ones that I really wanted to focus on were some of the highlights that came from the integration of mobile CT screening, as well as from equity in CT screening. What I'm showing here is a couple of the locations that presented on their current mobile lung cancer CT screening projects. This isn't necessarily all of the mobile lung cancer CT screening programs in the world, but rather the ones that presented at this symposium. So there are mobile LCS programs that were presented about from the UK, from the US, from Brazil, and from Australia. The one from the US was actually presented by Melissa Wheeler, so I'm not going to spend too much time talking about it because she has a great presentation for you later today. But really what we wanted to highlight from this symposium is that mobile programs are rolling out worldwide. They are happening in areas that focus locally, such as the UK, where they're really looking at high density screening in areas that are experiencing high barriers to care. They're also rolling out in areas that are serving a large regional population, such as in Brazil. And the Australian program was really focusing on serving a remote population. So these programs are tailored towards the specific populations that they need to serve. And the design is extremely important. So this isn't just about adding another CT scanner, it's really a program, which is something that Steve sort of alluded to. the UK, for example, found that many participants were not comfortable with the word cancer. So when they rolled out their program, they called it the lung health check or the targeted lung health check. And so making sure that this design really involves that community engagement and is really in conversation with the people that need the most support is a critical part of making a successful program. The other thing that was a really important highlight that I took away from this conference was that the sort of return on investment can be even higher with multiple services on board. So almost all of these programs had both lung cancer screening and smoking cessation on board. That's a very common thing to see together. But for example, the program in Australia also had a heart check on board, a spirometry on board, as well as audiology checks, and even a GP and a nurse practitioner. So it's really interesting to see what other opportunities can become combined together to make these programs really successful and really offer a lot of services to the people who are coming to them. So that's the sort of brief highlights from the World Lung CT Symposium. And these insights are also very much aligned with the reports that we've produced. So if you haven't already had an opportunity to read some of those reports, I think we'll be alluding to where you can find them later, but they're on Lung Health Foundation's website. And with that, I will pass it back to Steve for any last comments before going over to Lisa Jackson.
No, that's everything for me. So Lisa, go ahead and take it away.
Thank you for inviting me to present on Indigenous insights as we explore mobile lung cancer screening. 3 areas that I'm going to cover today are First Nations, Inuit, and Métis population in Ontario, the 3 R's of reality, relationship, and reciprocity, as well as insights into Indigenous health. Sorry. So some demographics for Ontario. This map is a political representation of where the 133 First Nations in Ontario are located. Ontario is a very, very large province with the highest number of Indigenous in the country. 78% of First Nations communities in Ontario are located in Northern Ontario. 1 in 4 First Nations communities in Ontario is a remote community accessible only by air year-round or by ice roads in the winter. Ontario has the highest number of remote First Nations in Canada. 23% of First Nations people in Ontario live on reserve. Of the 58,000 people living on reserve, 93% identify as First Nations, with approximately 7% identifying as Métis, Inuit, or other Indigenous. Sorry, with the statistics, we talk about urban, rural, remote, or special access. In this instance that I'm talking about, urban describes communities within 50 kilometers of a nearest service center or community or city. Rural or remote is between 50 and 350 kilometers or more from the nearest service center or city, respectively, with year-round road access. Special access means no year-round road access to a service center. Ontario has the largest Indigenous population in Canada with over 374,000 registered. The Indigenous population in Ontario has increased by 54% from 2006 to 2016. 2 explanations for this large expansion is the natural growth as well as an increase in Indigenous people voluntarily self-identifying. Indigenous people represent 2.8% of the total population of Ontario, and the average age of Indigenous population is 33.6 years compared to 40.7%, 40.7 years for the non-Indigenous population in Ontario. There are over 120,000 self-identifying Métis, as well as over 3,800 Inuit, which represents 1% of that total Indigenous population. So we talk about the 3 R's, reality, relationship, and reciprocity. There's a high prevalence of commercial tobacco use among First Nations, and it's concerning. First Nations men and women living on reserve are nearly two-thirds, are nearly two to 3 times more likely to smoke cigarettes than non-Indigenous men and women, retrospectively. Without immediate action, the further burden of lung and other smoking-related cancers will cause unnecessary illness and deaths. Approximately half of on-reserve First Nation households and 22% of off-reserve First Nation households are food insecure. Disparities can be partly attributed to the disproportionately high cost of food in isolated northern communities. Social, economic, and geographic factors can limit the degree of control people have over life circumstances, including access to and affordability of healthy food options and basic healthcare services, and can therefore have a major impact on the risk for further development of chronic diseases such as cancer. When we're talking about the relationship, how do we build those relationships and connections with communities when we're looking at the urban, which is within 50 kilometers, or the rural and remote, which is 50 to 350 kilometers or more, and then the special access where there is no year-round road. What does the reciprocity look like? Given these inequalities, it is perhaps not surprising that the health of First Nations is, on average, poorer than that of non-Aboriginal Canadians. At a national level, First Nations men and women have life expectancies lower than life expectancies of non-Aboriginal men and women. And I'm playing with the terminology of First Nations, Indigenous, and Aboriginal. It depends on where the sources that I pull the information from. If you're ever concerned or need to know what is the proper terminology, just ask who you're speaking with. Aboriginal nowadays is tied to the language that are in usually funding agreements with different service providers. So responding to the diversity of First Nations communities, how do you value cultural competency and cultural safety and Indigenous knowledge, and understanding the role of language with mental wellness? First Nations leadership, youth, community members, and elders have made it clear that culture must be at the center of our mental wellness. Culture must not only guide our work, but it must be understood as an important social determinant of health. And this is a model from the First Nations mental wellness continuum, with the varying degrees of the work that's gone into developing it. So with the social determinants of health for First Nations people, cultural identity and participation in cultural activities, access to cultural lands, along with connection to family, kinship, are recognized as protective factors and can positively influence overall health and well-being. The First Nations health authorities talking about the social determinants of health is another way of talking about the everyday things that impact a person's well-being. This could include providing opportunities to connect or reconnect with culture to help build a sense of self, establish positive relationships, connect to community, and balance one's emotional, mental, physical, and spiritual health and wellness. First Nations people have long held holistic understanding of health and the diverse factors that impact well-being. It's not just the absence of sickness, it includes mental, emotional, physical, and spiritual health, which are influenced by many factors, including our environment, our social connections, housing, and income. So tying it all together, how does all of that fit in this quick little 10-minute talk? When we talk about the benefits of mobile lung screening, I think we really need to think of the language we're using. Instead of using underserved, underprivileged, historically marginalized, strategically undervalued. I've come across that, and it really spoke to me. How do we reach remote and isolated communities with this mobile lung screening? Depending on how it's rolled out, it would reach varying demographics and geographic locations. It would answer the issue with transportation or lack of transportation, the lack of family physician. Because where we're at present day, we're looking at the intergenerational trauma and its effects from colonialism, the Indian Act, residential school, loss of culture, language, and identity, and the social determinants of health that affect a lot of our First Nation communities, such as poverty, well water advisories, housing shortages, food insecurities, and environmental contaminations. And that's specific to healthcare. There are stereotypes and prejudice within the system. What does the communication look like? What are the barriers, and is there a lack of translation services? And there is a lack of trust for the medical system. Many people may not have a family physician. There may be poor coordination of care, jurisdictional issues between municipality, the province, and the government, and racism in healthcare, as well as out-of-pocket expenses such as drugs and travel, hospital settings, and travel costs. So having the mobile lung screening would in effect help alleviate some of these issues. And the other part is having service delivery in a safer format by healthcare providers that are trained in culturally safe practices. And what that look like and what does that mean? We can elaborate further as we develop further in this work. Successful engagement looks like bringing together, Indigenous as well as service providers to work together to fulfill the needs of this engagement, community involvement, and then, having a successful mobile screening. And here are some of the sources that I utilized in this presentation. Thank you.
That was excellent. Thank you, Lisa. Very much appreciated you coming to give us this talk about this very important topic. I just want to remind everybody before we switch over to the other speaker that we will be having a panel discussion once all the speakers have completed their talks. And if you'd like to ask some questions or if you want to learn more about something that they have been talking about, please note that there's a question and answer thing right at the bottom of your screen that you can click on and ask your questions. And so that we'll have something to discuss during our panel discussion. So please feel free to ask away. This is your opportunity to do so. So just remember to do that. And I'm going to move on now to Dr. Laura Pripstein from Sherborne Health, who's going to be giving us some information regarding equitable access to lung cancer screening. Thank you, Laura.
Thanks, Lisa. I just also want to make sure when I share my screen that I'm in the right mode. One second. Can you see that okay?
Looks perfect.
Okay. Okay, well, hello, everybody. Thank you for inviting me to be on this panel. I'm excited to be here. My name is Dr. Laura Pripstein, and I've been practicing family medicine in the downtown East Toronto area for the last 18 years. I work at Sherborne Health, which was founded initially to serve marginalized populations in the downtown East. The objectives from my part of the presentation is to give you a community perspective working with clients who face social determinants of health. I'll tell you a bit about our organization, who we serve, and briefly discuss health equity and the barriers our clients have with respect to cancer screening, and some examples of creative cancer screening initiatives we have implemented to help level the playing field and get our clients screened for early detection and improving health outcomes. Also showing a bit of how a mobile lung screening program can be helpful for our clients in the downtown. So as I stated, I work at Sherborne Health. It's a family health team located in the downtown east of Toronto. We provide services and community programs focusing on 3 priority populations: 2S LGBTQ, people experiencing homelessness and housing precariousness, and newcomers to Canada. Through an integrated health service model, our clients can access primary care, mental health services, dietitians, harm reduction supplies and supports, and an inpatient acute respite care program. We have community programs and capacity building initiatives, hopefully enabling people from diverse communities to achieve wellness. But notably, Sherborne has operated a health bus, which I will speak to in a subsequent slide, to help with outreach and meeting our clients in the community and further decreasing barriers to receiving care and building relationships and trust with our community. And I'll show how that parallels a mobile lung program. I think it's well understood that people who face social determinants of health have poor cancer screening rates and therefore poor health outcomes. When it comes to health equity and cancer screening compliance, we hear directly from our clients some reasons why they don't get screened. In my experience, once I refer some of my marginalized clients externally for testing, the no-show rate and lack of follow-up are high. But I do know that these clients care about their health. They either have competing priorities, food, shelter, money, or they struggle with mental health issues that make navigating the system difficult. Or simply they just don't feel safe in a hospital setting. My experience at Sherborne are definitely reflected in the data. The Ontario Cancer Screening Performance Report of 2023 has data that specifically focuses on equity in cancer screening. This graph shows that people with the most material deprivation, and it's on the green on the right, have the lowest screening rates, leading to poorer health outcomes. So as I said, I did want to speak about our mobile health bus and how we've used the bus to address inequities in healthcare. For the past 22 years, Sherborne has run a mobile health clinic to serve homeless and underhoused people who we know suffer from a wide range of health problems, and the severity can be exacerbated by extreme poverty and delays in seeking care. The bus is staffed by nurse practitioners, case managers, program workers, community support workers, and other specialized care providers. Recently, we had a chiropodist on the bus for some satellite clinics, which is a new program for us. We see people who do not have family doctors or nurse practitioners, or people who do have family doctors and nurse practitioners, but don't feel connected or comfortable seeking care in the organizations those people work. They feel more at home and they trust the community, and accessing the bus is their preference. A question I do get asked is why a mobile health clinic in a big downtown city like Toronto, where there's no lack of primary care services. And what I can say is that you can have the services available, but if it isn't accessible or low barrier, or if people don't feel safe seeking those services, they just won't go. So we have the health bus often parked really close to our building, sometimes even in the parking lot, or just down the street at a church, and people will come to the bus who wouldn't normally come into our building. We're meeting the clients in the community, and some prefer accessing their care this way. Eventually, over time, sometimes they do build enough trust that they come into the building and seek care with us directly. So like the bus, we've also worked with our clients to help design other initiatives that address some of the barriers to preventative health care. We have a drop-in program called WINC, which stands for Women in Need Clinic, to support cis and trans women who are homeless and street involved. We know from our internal cancer screening data that these women have lower screening rates than the rest of the organization. One barrier they identified was fear and anxiety going to an external clinic for a scan by themselves. Lots of reasons given for this, lots of reasons that they gave for this, ranging from poor previous experiences with healthcare to fear of the test itself. So because of this information, I was able to work with St. Mike's Breast Cancer Screening Program, who agreed to allow us to come as a group for some visits. We organized 11 women for the first group who agreed to sign up for this initiative. We served a hot lunch, and over the lunch, I discussed with them what the test was and what to expect, and we all drove over together to the hospital. Notably, out of these 11 women in the first group who attended, 3 were called back for repeat scans, and 1 biopsy was needed, and early cancer was detected. We also have other initiatives that we use our health bus for. One was PAPS on the Bus, where we were screening street-involved women in the early hours when they were out and about. This included STI treatment and general assessments as well. Now we are recently offering fit testing to our homeless clients on site in our healthcare program. We don't have access to private bathrooms or don't have an address to send these colorectal cancer screening kits to. So now how this relates to the mobile lung program. I'm excited at the prospect of offering such a program to my clients who won't otherwise get screened in hospital. I do think this will have a big positive impact on population health for all the reasons I've listed here, and learnings from our cancer screening initiatives and feedback from our health bus users. This program is co-designed, it's creative, it aims to enhance client experience. It likely will decrease no-show rates, and I believe strongly that it will increase population health outcomes for all, and not just for the more socially and financially advantaged. Thanks.
Thank you, Laura. That was excellent. The work that you guys are doing is fantastic. It's really amazing. And I'm so proud that I know you and that you're doing this work. Thank you very much for sharing that with us and letting us know about the programs that you have and some of the successes that you've had with those programs. We've had some really great speakers already, and I'm sure that you have many questions that you'd like to ask the speakers. We've got a few already in the Q&A and in the chat as well. So I'm going to bring back Stephen, Lisa, Christopher, and Laura back on for the panel discussion. So we'll be doing that right now, and please feel free to ask away. I'm going to start with some questions in the Q&A. So Christopher, can you comment on the complexity issues that were raised at the World Lung Conference, identifying folks who are eligible, follow-up scheduling, and others?
Yeah, absolutely. So I saw this question earlier, and I've been trying to think over how to answer it since it's quite a large question. Um, I think I'm going to put follow up to the side for now because I'm actually going to address a little bit of the question of, how would a mobile program really effectively follow up people later? And I don't want to spoil that for everyone. So, keep a lookout for that later. But in terms of identifying eligible folks, I mean, I think that what we think currently is most feasible would be that we would align with whatever the province is doing, right? So we would still be looking at the eligibility of what is your smoking history, what is your age, when did you last quit smoking, and then doing a risk calculation and seeing if you'd be eligible to join a screening program. And so really it just comes down to educating people about the fact that there are certain risk factors and that if you think you might be at high risk, you should talk to someone or consider self-referring to a screening program. And I think that was somewhat reflected at the conference as well, that many of these programs are not necessarily implementing new eligibility criteria, but rather following the criteria that already exist, and then really doing the work on making sure that they get to where people are so that even if they are eligible, they can be screened.
And just to add on to that, Christopher, I think there's a lot of work that is ongoing right now where there's a lot of research around things like age cutoff rates, also talking about the non-smoking population that is occurring. There's various screening questionnaires that are being researched now, and we're hoping that those two different areas around age and risk factors could eventually be incorporated into the Ontario program.
Great. And along with the same person who's asking the question, commented that my understanding is that current low-dose CT screening programs are only reaching between 6 to 10% of eligible patients. How does mobile lung cancer screening address these poor uptake issues?
Yeah, so if I can jump in on this, it's interesting that you bring that up. This was actually also something that was touched on at the conference. I think, I don't know where you're getting this particular number. It is very common to cite around 5% as the estimated reach based on some old data from the behavioral risk factor surveillance system out of the US. And at the conference that was actually brought up is that still relevant? And some of the people there were thinking that it's actually probably closer to 20 to 40%. It's really a state by state number because of the fact that each state has a different way of covering different health insurances and the ways that each person is able to access the program. So it's a little bit inconsistent. But they think that there's actually been a lot of progress in how much lung cancer screening is known about in the past 20 or so years and how much there's uptake. So at the start, there's more uptake than I think a lot of people think there is. And as we've sort of alluded to, it's really important to sort of meet people where they are, both geographically and in terms of their comfort and trust level. So I imagine that if you're building an explicit program that goes where people are, that will increase screening rates in that specific population.
I'm on mute. I know there was a question in the chat, but I'm gonna I'll come back to that one. I did see it. There's a question here. How many people does the Sherbourne mobile bus screen in a day, or month or a year?
So I was just looking at our annual report to get the answer for that. We have 7,027 total contacts, 1,704 clinical visits with nurse practitioners, and 281 help bus stops. That was the last year.
Fantastic, thank you. I'm going to come back to this comment in the webinar chat. It's fantastic to see such a strong focus on community partnerships. In Ontario, we've seen a great success with mobile coaches for breast, cervical, and colorectal cancer screenings. Are there any plans to collaborate with these existing programs to integrate lung cancer screening as well? This could be an exciting opportunity to expand access and build on the established infrastructure.
I can jump in on that, Lisa. So great question. And we certainly hope absolutely yes to that. Of course, there are significant differences between the breast screening program and the lung cancer screening program. But that said, the major part of both programs is they're really trying to reach, common participants. So the opportunity to increase kind of the awareness of the programs, cross referrals between the both programs is an excellent opportunity. And I think the other piece to it is it takes a long time to develop the community relationships with organizations, even just, for example, finding places to park the units. There are very specific requirements that are there. And both of the programs in Northwestern Ontario and in the Hamilton, Niagara, Haldeman, Brant region already have a significant number of relationships that are established. So it would be great if we could, potentially piggyback on the great work that they've done so far.
Yeah, and I can definitely envision you've got the truck with the mobile CT, but also right beside it is the mammogram as well. And there's, possibly another one where people can go in and get their pap smears, their fit test, the discussion around all of that as well. If they're already there to be screened for one modality, why not get them all for all the different modalities as well? I mean, that probably would work better than trying to have people come down, especially if they're in remote places that need to come in to another remote area to do this, that you're catching them all modalities at the same time. So that would make the most sense. Sometimes what makes the most sense doesn't necessarily translate in what actually happens, but it's would be lovely if we could do that. There is another question in the Q&A that asks, if you had your home mitigated for radon, will that be criteria for patient screening? At this point in time, I can probably answer that one. At this point in time, I don't see that happening in the near future as being added to the criteria for lung cancer screening. And they're very, very strict even now, even with just smoking cigarettes, and they don't include pipes, they don't include vapes, they don't include anything at this point in time, just because we don't have the evidence to back it up and support it in terms of what puts you at risks. But that's not to say that, and that's for the organized cancer screening program. So remember, we have organized cancer screening programs where you have to meet specific criteria, but then there's the opportunistic one. So if you really feel that somebody might benefit, or there might be some indication for doing so that's clinically judged, I'm not putting this out there. And if Ontario Health, Cancer Ontario is listening and is in the audience, you didn't hear this from me, is that obviously that might be more, especially if they're symptomatic, more diagnostic, if anything. So that is something that I'm sure is being looked at. And I know that radon is being looked at specifically. I know that there are a number of risk factors for lung cancer. Many of them are occupational related. So there's many occupational hazards that could cause lung cancer. And so many of them aren't included and probably are just as risky, asbestos and silicosis and other toxins as well, that we don't put down as criteria for screening. And I'm going to go back to the chat because I think something popped up. And this is from Ontario Health Cancer Care Ontario. This is from Jessica Moffat. One area of focus as a minimum could be to conduct a preliminary risk assessment for lung cancer while participants are present on these coaches for their mammograms or other screenings. This approach could help streamline access and optimize the reach of lung cancer screening efforts until full mobile lung cancer screening program is available in Ontario. So kind of related, but not, but I'm not sure where that's going to fit in, but certainly with more evidence and research, I'm sure that other risk factors for lung cancer will be included in at some point in time. I just
Lisa,
support it. Yeah.
oh, sorry, just to jump in on that. It's a great comment. And, you know, one of the things in the Ontario pilot was that there's the referral criteria and then the eligibility criteria. And there was about 35% of patients who were referred but not yet eligible. And so it's really, you know, the questionnaire, the risk calculator questionnaire is not too difficult. It's really, you know, how much time does a person have on the you know, the Screening for Life coach. But it's definitely not difficult to just ask for the referral criteria and then to ask the simple questions to create a score around the risk calculator, that you are ensuring then that these are the potential, you know, eligible patients that could go. So it absolutely can be done. And it's a great point, and it's really just a matter of the additional workload and that the staff could take on while on the Screening for Life coaches.
Great. Is it a comment in the chat as well from Angus Pratt saying, I love the Pink and Pearl campaign that is linking mammograms to lung screening. Even though it misses 50% of the patients, it is a start, which is great, which I think is also a great idea, as one of the things that I alluded to get them all at the same time. And I think that's it. Do we have any more questions at this point in time? We've got a couple more minutes. Anybody want to comment or say anything about this so far?
I guess just one last quick comment around the complexities around access. If you think about all the challenges around imaging services and the complexities of that, you know, you can start off about, you know, what is the awareness? Do people understand the risk factors? Do they understand the importance of, even if I don't feel symptoms, I should get screening? You know, and then you have additional barriers such as the ability to access it. Do they know where the sites are? Do they have the funding to get there, you know, to pay for parking, you know, all these kinds of things? Is there referral opportunities? There's a lot of, you know, provider barriers in the system that can impact the referrals. And then, you know, as Lisa talked about, some of the challenges around navigating a hospital, you know, getting in and wanting to do the services, feeling safer there. So it's quite a complex question, actually, as to, you know, why a person may or may not have screening done, and whether, you know, what is the best way to increase the uptake of lung cancer screening.
Yeah. There was another question in the chat. You were talking about some of this, Stephen, was what's holding the 70% up from getting screening? Is it a fear of being asked to quit smoking?
Well, I think that's certainly one of the questions around that. When you look at some of the both patient and physician barriers, you know, there's the whole issue around the stigma of smoking. But when that patient is in that physician's office, sometimes they, you know, want to avoid those kind of difficult and challenging discussions in that. So sometimes if they don't get past that, then they don't even get into thinking about lung cancer screening. But yeah, I think, as I just mentioned, it's smoking and stigma and the fear of quitting is a very important factor, but it's multifactorial as to the challenges that are keeping from a significant uptake occurring.
Yeah, and I noticed it anecdotally, even with my own patients, when I would bring it up. And I just felt that that was something that was one of the issues, that because when we bring it up with my patients who were smokers, a lot of them did not want to be screened. And so if I, just ask, well, what's bothering you about it? And they're like, well, I don't want to be told I have to quit smoking to participate in this. And so I thought this would be a great resident project. And I had 2 of my residents do this as their resident project to find out why people were turning down lung cancer screening. And they had this great project, and they were going to ask all the people who were eligible whether they agreed to participate or not agreed to participate. So it was factors that would enable or not want them to be screened. And they did a full literature review, and there was a ton of literature out on this. And unfortunately, the pandemic hit, and they had to stop their project, and they couldn't do it because it was, of course, it happened. Their project was 2019 to 2020, and so we never ended up getting it off the ground. But I thought it was anecdotally noticed it, and it was a great project, and there's a lot of literature out there as well. And again, in the webinar, just to bring people's attention to it, there's an e-module, CME accredited, offered at UBC on how to approach these screening and smoking cessation conversations. Thank you very much, Angus, for sharing that with us. And I'm gonna just come back to the Q&A. And Angus, I had another question. Christopher, you had mentioned states uptake stats. Do you have Canadian stats? How many provinces even have a screening program?
That's a great question.
Christopher is just typing, it says here.
I was just typing it up, but I'll answer very briefly because I know
Yeah.
we're just about at time, I think, for the Q&A.
Yeah.
I'm not sure off the top of my head. The stats that I was telling you about from World Lung were from there, and I don't know off the top of my head if we have stats from Canada. As you may be aware, most of the programs here in Canada are in their nascency for formal organized provincial programs. I'm sure they exist somewhere. There are 4 provincial programs that are either rolled out or are about to be rolled out shortly. They're in British Columbia, Ontario, New Brunswick, and Nova Scotia. And there are 2 pilot programs, one in Newfoundland and Labrador and one in Alberta. Some other provinces are in early planning stages, but those are the only ones that are sort of actually active in some way.
And before we, it says here Alberta is closed now. Before we wrap up the panel discussion, one final question. Is there and what is the current wait for screening at the established sites? I know in Ontario we're having some wait time, significant wait time in Ottawa. And we're starting to in Toronto as well at one of these are the pilot sites in Ontario. We introduced a spoken hub model now, and that's helped alleviate some of that. But I know that we are starting to see the wait times now starting to come, especially now as we're starting to get into the repeat CT screens as well. But I don't know if anybody knows those offhand.
I don't know them offhand. I know that they vary between sites. Some have been more successful, and I think Ottawa was really successful in their approach to implementing the program, and that may have resulted in a little bit higher capacity concerns in that. But the pilot program would say that it did not impact current wait times. But I think as the lung cancer screening program expands and it becomes focused and the awareness gets created, it will potentially impact CT scans overall, not just specific to lung cancer screening.
Great. Well, thank you for this insightful discussion. This is great. I just want to let everybody know that fortunately, Lisa Jackson had another engagement that she had to get to, so she's jumped off the call. But we will provide her contact details in the chat in case you'd like to get a hold of her directly. So I'm going to move on now. We next have our next speaker, Melissa Wheeler, who unfortunately couldn't be with us today. She had another engagement that she's attending. But we will play a recording of her talk that she has provided for us. And she has authored a grant proposal that resulted in a $1.6 million funding for the United States' first mobile lung cancer screening bus as part of the Lung Basis for Life program. So I'm going to let you listen to that.
Hello, everyone. So great to be here with you today. My name is Melissa Wheeler, and I'm the Administrative Director for Disparities and Outreach at Levine Cancer, Atrium Health, also part of Advocate Health. And I'm here today to share with you the story of how the first mobile lung cancer screening bus in the United States was born in 2017 and where we are today. I have no relevant financial disclosures. And we're really going to talk about the nuts and bolts of the US Lung Bus. There are three primary objectives for today's talk is to first focus on how was the Lung Bus born? How did we come up with this concept? Why was there a need? How we conducted our assessment to get to the point of operation, even a little bit on construction. The second part, we will focus on the objective of the wheels on the bus go round and round, and I hope that song doesn't stick in your head all day after that, but we'll take a peek at a day in the life of the Lung Bus, and we'll review some of the early challenges that we faced in the launch, and then also some of the impacts, some of the outcomes, and why we're so excited to share the news of this project with others. And then in our third phase, we'll talk about, the places we will go. Some of the most common questions we get are around funding, sustainability, and growing our program to reach those that need us the most. So we'll cover those as well. And I've left plenty of information at the end so that if you have questions for me in the future, you'll know how to reach me. So how our Lung Bus was born. Again, we are part of Atrium Health. We're Levine Cancer. Our main headquarters sits for the Cancer Institute in the heart of North Carolina and South Carolina. We have a 30-county catchment area. And for my team in particular, our mission is really to reduce cancer health disparities by focusing on eliminating inequities in care. And one of the things that we know to be true is that access can be a predominant issue for many of our underserved and vulnerable populations. So our team works together with community partners to design really innovative approaches to help overcome those barriers to care. Our team is comprised of a physician assistant, we have RN program coordinators, and then we have a unique position on our team called a cancer program development specialist, which is really a public health boots on the ground person who helps to navigate towards resources. And as we go through the presentation today, you'll see quickly how they fit in to each of the pieces of bringing the Lung Bus to life. So our three primary pillars that our team focuses on in disparities and outreach, first, of course, is prevention and education. We don't just want to detect disease, so we've layered in prevention education to every screening program that we have, every opportunity that we have to connect with our community partners. Then, of course, we have our screening programs. And our screening programs are conducted at no cost to the individuals because we primarily serve uninsured or underinsured individuals. But it's not just lung cancer screening. We screen across primary tumor domains. We screen for breast, colorectal, prostate, head and neck, and skin as well. And then key to this process, all working fluidly, is of course our community partnerships. There are only 18 of us on the team, and we serve a 30-county catchment area across what we affectionately call the buckle of the Tobacco Belt. So we need a lot of community partners to help us connect with resource to ensure that the right patients are referred at the right time. So again, those 150 partners are really key at a bi-directional relationship. So the majority of the patients that we serve are not part of our health system. They're actually outside of our health system, and we navigate them to their own health system within their community. And we'll talk more about that as we move forward. But the arrow that you see across the bottom is probably the takeaway that I want you to hold on to the tightest is we really focus on pre-diagnostic navigation, meaning we operate under what we call whole human care. We look at the whole individual, what all those barriers might be, what all of the needs might be. Each of our screening programs includes that assessment of barriers to care, because if you're hungry at the end of the day, if we find a cancer for you, it's not going to be the most important thing to you. So we'll talk about how do we address those barriers once we've screened for them. There are other health issues too that are difficult to navigate for our patients. So we make sure that our whole team is trained in that pre-diagnostic navigation. So what you're all here for, our Lung Bus. Back in 2016, we were looking at our cancer data registry, and much like the rest of the United States, we saw that about 75% of our patients were coming in at stage 3 stage 4 disease, leaving us very little time for a positive, impactful outcome and very little quality of life for those individuals. And if you're stage 3 or stage 4 at your very first visit, it's drinking from the fire hose and really trying to address things in a timely fashion. And we recognize that we weren't able to do that. So based on what we learned early on in our mobile mammography program, we have a mobile mammo program called Project Pink. We also have it specifically geared for the Latino community called Proyecto Rosa. We learned a lot about what it was like to bring care to where people are, how that helps to build trust, a sense of community, resource, and it actually improves show up rates because individuals, it sort of normalizes the screening process. So we hypothesized, why can't we do the same thing in lung cancer that we do with mammography? So I spent about, a couple of weeks. I made 43 phone calls to different companies across the US because a unit like this didn't exist yet. And on my 44th call, I reached the team at Samsung Neurologica, who built the mobile stroke units for Cleveland Clinic. And so they had the technology in the field, but they had not yet tried it in a lung space, but they thought that they could do that. So we were able to come up with a proposal for a robust screening program. So this isn't just about the screening, it's about the other program facets as well. And we were able to get 1.6 million in funding from Bristol Myers Squibb Foundation to start the United States' first mobile lung cancer screening program called Lung Basis for Life. And it was really about bringing awareness, normalizing screening, educating our communities and our primary care physicians about proper screening techniques, as well as our goal was to improve the survival for the communities that we were serving. And so there were several really key strategies that we knew had to be a part of this. It wasn't, again, just about that screening. There had to be community-based education. We had to have the ability to screen in our regional areas. There had to be high-touch navigation services because oftentimes it isn't just the first screen of a low-dose CT where we find an issue or a positive. So we needed to make sure that we could get patients back to us. And then, of course, again, we talked prevention education. We needed that tobacco cessation woven into the program. And I'll talk about how that's done as well as how we provide it for more than just individuals being screened. But that's how Lung Basis for Life was born back in 2017. And I will say our first screening day was an adventure. We had 3 patients and a drive-by shooting. So it was a little bit of a hectic day, but we were all safe and we were out again by the next week. We currently screen 3 days during the week and we go to 30 different counties. And we go to each of those counties every 3 months to make sure that we can get within the window of follow-up scans so that the patients we screen the first time can come back for a follow-up if they need to. So here was the first unit that we built. It's more of a box style truck. We called her Hope because she was bringing hope to communities that otherwise did not have it in the first place. And she traveled to many communities that didn't even have access to low dose CT. So more than 3/4 of who we serve are rural patients at this point, even though we do serve some urban areas. But as you can see, there's a slide at the front that pops out and accommodates for the CT scanner to slide back and forth over the patient. And again, that whole box unit there is lead lined and the scanner itself is interior lead shielded as well. We do have a mobile driver. We're not required to. It doesn't meet the weight requirement for what we call a commercial driver's license CDL here in the United States, but we included that as a best practice because our health system does have a mobile medicine program. So there is an EMT that drives and sets us up every single screening day wherever we go. And he's there for safety as well so that he can escort patients on and off. There is a wheelchair ramp at the back of our unit. And this is mobile unit number 2. Based off the success of mobile unit number 1, we were able to write an additional grant to the Leon Levine Foundation for $1 million to purchase our second unit and included our staffing program. This one's a little bit more of a Winnebago style, and that was based on Samsung's choice early on, but worked out well for us because it has a consenting room at the back. We do operate a clinical trial on this bus, so it's important for us to have that private space. But you'll notice the team sitting out front. We are very strategic in making this a very comfortable environment for folks who come up. We can take walk-up orders. So oftentimes our team will just be out there greeting, meeting, welcoming people where they're at. Oftentimes individuals will just come up and ask questions because they have not seen a unit like this before. But the more time we screen, the more normalized the process has become. So these wheels on the bus go round and round, and what does that look like on the day to day? And what were some of the impacts that we saw? So of course, the primary block is free screening and monitoring of follow-up. We provide that initial low-dose CT, but then we follow up as needed. Positive findings are presented at our nodule conference, and we return every 3 months to keep within the window. But we do focus on other important pillars that I would encourage anyone who's considering a screening program of this nature to implement within the realm of to keep it as programmatic as possible. So social determinants of health assessment is incredibly important, particularly in the populations that we're serving, because many times they are without resources, and we need to shore those up before we find a cancer diagnosis. So one of the primary needs that we find in our communities is food supply. I tend to shy away from using common terminology such as food insecurity, because I've never met food that's insecure, and it tends to label the patients in a shameful way. It's really an inadequate food supply. But transportation is also another one of those key issues that we focus on. We provide immediate solutions to those as well. But we also cross all of these individuals into other applicable screenings that we might offer. So we bring FIT cards on board, so we can do colorectal cancer testing. We can draw for a PSA to do prostate screening in the field. What we've learned with this population in particular is if you can get as much done as possible at the time that you have someone there, the better. And then we navigate all of those findings. And we assess, again, for additional barriers like primary care, mental health resource needs, and we connect those individuals. So we bring with us immediate solution in the form of bus passes, gas cards, food vouchers, but then our cancer program development specialists that I mentioned to you earlier will connect to the local resources within the county that we're serving. The tobacco cessation, incredibly important second pillar to this, again, knowing that we want to prevent a cancer if we can. So our team they're all tobacco cessation certified. They do the assessment. They do the plan for quitting. We can have the nicotine replacement therapy shipped to the patient's doorstep within 48 hours. But we don't just help the person being screened to stop from using tobacco, because if you're in a household of 4 and all 4 smoke, but only 1 quits tobacco, then the chances of that staying that way are slim to none. So we provide the tobacco cessation assessment, NRT, and follow-up care through very high touch counseling for the whole family, whoever in the household who is struggling with addiction at that time. Then we navigate all of these patients very, very closely so that we don't have a loss to follow-up. We have a less than 5% loss to follow-up rate. We provide all of the results directly to the primary care physicians, and we communicate with the physician as to what their preference is. Do they want us to call the patients? Do they prefer? But every single patient has our direct cell phone contact number, so that if they don't hear their results or they have questions about their results, they can contact us immediately and avoid them going in a delay and kind of increasing anxiety. And then we present all of those individuals at our nodule conference to determine the next best steps. And by doing so, we're also able to advocate, particularly for those individuals who are struggling with resources, can be incredibly important when there's a need for follow-up diagnostics. It also ensures that we get the proper charity paperwork put in place, Medicaid applications, things like that. And then, of course, it's incredibly important to mention that we do have an under 55 clinical trial. It's actually under 50 now based on the Nelson results. But because we are in the tobacco belt, we noted very early on and after the launch of the bus that many individuals did not fit the criteria for the national lung screening trial because they had the PAC per year history before the age of 55. It was not uncommon in the Carolinas for individuals to start smoking as early as 5, 6, and 7 years old as part of the farm culture. And so we started that trial, and we have a very heavy accrual because we're bringing that trial out on the bus to where people are, and we've normalized lung cancer screening. So just wanted to give you a little brief snapshot of kind of what the early results were showing us. Our very first 1,786 participants, 76% of those were rural, 66% were uninsured, and the other 34% were individuals that were part of the state Medicaid program, which is the government assistance program for our low-income patients. At the time we started lung cancer screening, Medicaid did not cover low-dose CT scanning. They do now, but we have such a high navigation, high touch process that we still continue to screen those Medicaid patients, but we do not bill the patient. We do not bill for any of our services. Our median age was 62, and our pack per year was above the average of what was initially a 30 pack, now a 20 pack. Our average pack per year history was 50. Our highest pack per year was 187, which translates roughly to 6.5 packs of cigarettes a day. We had about a 1-to-1 ratio. And in terms of who we're seeing come forward, it's very reflective of the communities that we serve. Now, I am not a clinician, but I was easily able, this was a scan from one of our first few patients. I was very easily able to identify the problem. If you look to the top corner of this screen, this gentleman was almost out of cigarettes on the day of his scan, and he included those in his pocket for his scan. We did publish that in The Oncologist. We did do some updates to that research, and we have an additional publication that's pending. So in the first 1,786, we found 43 lung cancers. We found 10 additional non-lung cancers. So of course, if you're scanning from, chin to hip, you're going to find other things. And so we were able to navigate those as well. 63% were found at an early stage. We had 163 that were highly suspicious lesions. And when we did an early estimate, we found that it could be a potential economic impact of a savings of 1.6 million per patient based on an early diagnosis versus metastatic lung cancer management. Now, I did include on the side there in the image, we use this bus as a multi-purpose. So we recently suffered in the Carolinas from a massive hurricane, Hurricane Helene, and many of our mountain counties were shut off from the outside communities. So we stocked up the bus and we took her up, and we were able to distribute hygiene products, cleaning products, clothing, and we'll continue to do that for the next 6 months while they recover. So it's not just a one-purpose unit for lung cancer. We screen for all kinds of cancers, we connect for all sorts of resource, and we're able to do all sorts of community outreach with the bus. So the final piece, and of course I could talk about all of these pieces all day long, but so if there are definite questions, you can always reach out to me later. But there are 3 common areas where I am asked to speak to, and of course, the first being funding. How do you pay for this? And my immediate answer to that is I will take PayPal, Venmo, Pocket Change, and if you write a check, it's 2 L's, 1 S. But in all seriousness, we have to be creative with funding. Look for corporate champions. We can't always look back to our health system and say, you should pay for this, because they may not have the resource or there may be competing priorities. But look at your industry partners. Look at folks who are really interested in this space. And sometimes it feels a bit like cobbling those pieces together. But if we don't cobble those pieces together, we'll never see the picture. The other question I get is about sustainability. And I am always a little bit intrigued by this question, because first of all, I don't know if I'll be here next Tuesday. I don't know that I'm sustainable, but more importantly, I don't want this to be sustainable. I want us to have better screening options. I want screening options to get so simple that every person can access them. So I think what it is it's about the now, and it's what we have, and it's how we can operate within this space while we're always trying to think innovatively about how do we get even better. And then the final piece, you see a cake here in the middle, and it's this analysis paralysis. Most folks ask themselves the question of what if this doesn't work? I challenge back with, but what if it does? And what if we don't do the work? Then nothing's going to work for the people who are suffering from this really terrible disease. If I were to give everybody that's listening a recipe for a cake, the first step for that cake is to turn the oven on. So I would encourage you all to turn the oven on, bake the cake. The first cake might not taste great, might not come out perfect, but as you move through time, as you move through iterations and you improve the process over and over again, just like we've seen with the lung bus, it gets better and better and better, and everyone is nourished at the end. And why do we do this work? We do it because it matters. This gentleman, his name is August. He actually gave us permission to share his story because he really credits us with saving his life and the life of his wife. He came to us at 59. He had been a smoker from his mid-teens. He had had a smoker's cough for more than 30 years, and we did his low-dose CT at no cost. And interestingly enough, we didn't find a lung cancer. We found a kidney cancer. We were able to treat him for his kidney cancer. He's now cancer-free, but we were also able to help him and his wife to stop smoking. I'm happy to report that 4 years later, he has started his own business and is thriving and doing well and enjoying spending time with family, enjoying spending time with his grandchildren. And he really attributes all of that to this really compassionate care and to the fact that we took a risk on a really crazy idea called a lung bus. And we continue to travel county to county, really hearing story after story of how this has changed outcomes for people. I really encourage you all, if you have questions, please reach out. Again, my name is Melissa Wheeler, and I really look forward to hearing your stories in the future about how you've launched your own. Thank you.
That was excellent, as you can see, and in keeping with the theme of wheels, you can see today with today's topic that we're not trying to reinvent the wheel here. This is something that's already being done and has already had some successes. And so how do we build on that in our own country with our own resources and what have you? So now what I'm going to do is I'm going to hand it over to Teresa Tang, who will describe more about the partnerships with the Alberta government, as well as the Alberta Cancer Foundation, and as well as her company that she founded, the 19 to 0, to bring mobile lung health units to rural communities in Alberta. Thank you for coming.
Okay, hi everyone. Wow, what a great talk that we just listened to. I'm just going to go into presentation mode. I only have one screen, so don't mind me as I kind of fumble around, so apologies. But my name is Teresa Tang, and I co-founded a health not-for-profit called 19 to 0. Call us the new kid on the block, perhaps, in the lung health space. So I thought I'd just share a little bit about the work that we're doing and how we started an initiative in Alberta recently to bring mobile pulmonary function testing and mobile CT scanning to hard to reach Albertans over the next few years. So just very, very quickly, our health not-for-profit is a national health not-for-profit that really emphasizes the strengths of a range of diverse in parties, from scientists to marketing professionals to academics to patients, like we were hearing, to community partners, like we were hearing today, as well as health professionals. And it's all with this lens of trying to understand unmet needs within our health system and really the behaviors of different Canadians within their healthcare, and then shifting them towards safer health behaviors or addressing those areas. And sometimes that looks like increasing accessibility, like the projects that we're talking about today. Just very, very quickly, at 19 to 0, we spend quite a bit of time thinking about what are those actionable insights that we can understand. So we have a primary research team that does focus groups and interviewing across the country and social media analytics using AI, NLP. But what we also really, really care about is doing something about that very quickly. And so when we think about some of those strategies, and we'll highlight one today around really leveraging the power of mobile health service delivery and the partnerships within community, is we spend a lot of time in the community. Our not-for-profit works very closely with newcomers to Canada, 2S LGBTQ communities, rural and remote municipalities, Indigenous, as well as actually a lot of employers and schools as well. Across the country. So community is a very, very important aspect. The other thing that's really important to us is actually public health communication. I'll call it public health for the sake of it. And really that's using insights to drive what would actually shift people's behavior within health communication. So we have these marketing campaigns, we'll call them, but they're very, very targeted to a certain type of health behavior that we want to see, and they focus their messaging and are tested within communities and use a lot of conventional and unconventional channels to reach those communities as well. And then very, very quickly, we believe in the power of policy and advocating and partnering with our governments. And so we've launched groups like the Adult Vaccine Alliance to get more coverage for Canadians around immunizations. But we've also launched groups like the Canadian Immune Compromised Advocacy Network, where we've been advocating for the immune compromised needs of Canadians across the country. And then lastly, in all these areas just relevant to how we're going to be looking at the work we're doing in Alberta is the education and practice change supports for our family doctors, our specialists, our pharmacists, and their health teams as well. So what are we actually implementing in Alberta? So in early 2025 and spring 2025, we'll be rolling out mobile pulmonary function testing. So that does include spirometry, that's the body box that we'll be including, and we'll be bringing that in a mobile sprinter van across harder to reach communities in Alberta or where there's higher need. The other mobile health unit, lung health unit that we'll be rolling out is a lot of what we're talking about today. A lung cancer mobile CT scanner that we'll be putting in a 41-foot truck, not too dissimilar to the first model that Melissa just showed us out of the US. And we'll be custom building this unit to meet the needs of Canadians and Albertans in harder to reach communities as well. And so just a couple of quick mock-ups here around that, what that looks like. This, we are expecting this unit to be available in fall 2025. And we intentionally did 2 units, even though I think it was Christopher's point, we've seen globally that you can actually put multiple diagnostic tools in the same unit because we want to just increase and maximize the reach we can. So we want to meet communities where there is actual need. And so what I was hoping that we could chat a little bit about today is actually the importance and the power of partnerships as a very key ingredient to success. Our work in Alberta spun off very, very quickly. I'll say it that way. In less than half a year, we were able to get a number of different parties to come together to really bring the thought leadership, but also the commitment that was needed for Albertans and Canadians around their lung health. And I really think that's because of a lens of partnership. And so at our not-for-profit, we've always really valued the interplay between academia, private sector organizations, non-healthcare organizations, community healthcare system, healthcare organizations. And really, I think it was a little bit of this lens that overlaid the thinking, to Melissa's point in her presentation as well, that really inspired a lot of our understanding of the challenges that Albertans were facing around their diagnostic imaging, but also what could be solutions that could come together very quickly. And so hoping to chat just very briefly about 3 areas within partnerships. One is funding. The other one is actually picking the right mobile health service delivery partner. And we've seen that's something that is incredibly important in the success in the partnership and being able to think through what you want to deliver. And then the third, which we heard a little bit about today, around the value of important partnering with communities and the actual health system itself to ensure that we're really meeting needs where they are, but we're also meeting groups where they're ready as well. So I guess just very briefly, our project or our initiative in Alberta is a 2-year initial proof of concept with already intentions around, even though Melissa noted it, sustainability and how we can actually continue to invest in these areas if successful. But our funding is really from public, private, philanthropic. We were able to leverage innovation funding from our government, as well as also the political support from our Minister of Health to really celebrate this initiative and really acknowledge it as an important area and actually make investments over the next several years. The other area that's important to consider, like many of the supporters who were able to make this policy forum possible, are our private partners. Because of the thought leadership and the quick thinking and willingness from the leadership of groups like AstraZeneca and Siemens Healthineers, we were able to remove barriers and really push forward leadership and thinking through what could it look like to have mobile lung health service delivery for Albertans. And we were able to partner with both AstraZeneca and Siemens and being able to think through this over the last half year. And then lastly is really philanthropic. And I would really emphasize that philanthropic is just so important. And we've seen this in global jurisdictions being a leading force for a lot of initiation of mobile lung health initiatives. And philanthropic funding is such a great way for our health system to be able to leverage innovative funding to invest in initiatives and ideas like mobile health service delivery in a way that sometimes our health systems aren't able to nimbly kind of mobilize. And so we think that there's a lot of strength in diversifying the investments when possible. But I would say that the one thing for other Canadian jurisdictions or other jurisdictions looking at this, we have seen other successful mobile lung health initiatives where you don't have all three come together. Maybe that's something down the road or more on the sustainability piece that you find, but you move with where there is readiness and where there is leadership. And so in Alberta, we've been able to leverage all three, but would really encourage other jurisdictions to really consider, or other honestly donors who might even be watching this, to think about how they could be a driving force with innovation in other jurisdictions across Canada. And then just quickly, one of the most amazing partners we've had in really thinking through the delivery of mobile health service delivery in the lung health space in Alberta has been our partners at ASO Medical. I think when we went globally, so we went down to the US to some of the other communities like Chattanooga, and we've spoken to the UK about their learnings. Picking that mobile health service delivery partner is so critical. You want to be able to pick a company that specializes in mobile delivery. To Stephen's point earlier, there are lots of considerations on which mobile delivery unit you actually choose for your community. In our case, we chose a truck. There's tractor trailers, there's seat cans, there's more stationary, even mobile units. And that consideration is critical. And there's a lot of unique challenges with bringing delicate diagnostic imaging equipment in a mobile basis. And so having a mobile service delivery partner that actually has experience in mobile, we think is critical. The other thing is there's so much great learning around patient flow and how to set up a mobile clinic. The space is very small. How do you sign them in? Where do they go? All these things like that. And so having a company that actually has experience with that patient flow is also invaluable. And the other one that we really think is important is that you want health service delivery companies to have experience with actually delivering health services in Canada. In Canada, unlike some of the jurisdictions we were visiting in the US where they were dealing with humidity and other pieces, we're dealing with in Alberta drastically cold temperatures, especially in some of our rural, remote areas. And I think it was it wasn't Lisa, but it was earlier we had heard about it was Laura, the conversation about sometimes you are going to remote areas where you have to use a barge or where you actually can't reach those communities. And so understanding what the Canadian landscape and the environment actually looks like and how to deal with some of those barriers is really critically important to the success. And then the last one, which might sound obvious, is when you're about to partner with a mobile delivery partner, check on their track record for success and timeliness. We've heard numerous times from many, many groups about delays in delivery, delays in setting up, and every time there's a delay, that's a delay to Canadians being able to access care that they could closer to home. And so picking the right mobile service delivery partner is critical and is something that I think groups should really be considering across Canada. And then just to wrap up, I think one of the key areas we've heard today is that partnering with the community and also partnering with our health system is critically important. And so we really understand that that is the big piece we're going to have to keep doing as we start rolling this out in Alberta. As some even noted in the chat, we're working right now actively to ensure that we have a lung cancer screening program that we can partner with, who have done a number of this foundational work for us, and something that we really want to see and see as a critical key to success for our mobile service delivery over the next couple of years in the lung health space. But really understanding where the needs are, assessing where there's actually readiness. In our case, there's so much more Indigenous community engagement we need to do, but we did have Indigenous Service Canada be part of our initial thinking around this. We previously worked with rural and remote municipalities and understanding their unique needs. Employers have already started to be very interested in associations with this and understanding the role that they can play in ensuring that their staff who are eligible for cancer screening get screened and are educated. And then so important will be all the work that we'll have to do to ensure seamless care and clinical pathways between specialists and our community and with our health authorities as well. And so just the emphasis on partnership on multiple levels. And so I think just to wrap up, our team is thrilled that we've been able to make this type of commitment in Alberta. We are more than happy to share our learnings along the way, and more than happy to sit with other jurisdictions who might be considering something similar around the ways we might be able to support or learnings we might be able to bring. Both ASO Medical and 1920 do work in other jurisdictions. And so we'd welcome the chance to connect with your groups, learn from great learning from your groups, and to be able to see what other jurisdictions across Canada we can be able to bring mobile lung health initiatives to. So thank you so much.
Thank you, Teresa. This is great work that you guys are doing out in Alberta. I just want to remind everybody, we're going to have another panel discussion after the next talk. So if you have any questions or anything like that, or comments that you'd like to bring up in the panel discussion, please feel free to put them in the Q&A at the bottom of your screen there. I just want to remind you that we will have another opportunity to have a discussion about the mobile lung screening programs. And so with that in mind, I'm going to pass it off to Stephen and to Christopher to talk about where we're at and some perspectives on mobile lung screening in Ontario. Thanks.
Try this again. There we go. Christopher, do you want to start off?
Yeah, sure. I'll go ahead and jump in. So thank you so much, Teresa, for that great look at how Alberta has sort of developed and is starting to roll out mobile screening. Now we're going to focus on the work that us project partners have done in assessing the feasibility of mobile trailer lung cancer screening program here in Ontario. So for context, the project partners that I'm referring to here are Healthcare Together, led by Stephen Graper, the Lung Health Foundation, and Jeffrey Liu's lab, of which I'm one of the research associates at the University Health Network. So we're going to look at some of our feasibility findings, at what we think are some of the remaining challenges for looking at implementing a mobile trailer program here in Ontario, and then some of our recommendations. And just really briefly, before I turn it over to Steve to talk about some of our preliminary feasibility findings, I just wanted to come back to this slide that we've already showed you about the stages of a mobile trailer lung cancer screening program. And talk about some of the learnings from the Ontario and BC pilot programs and from the international programs and how that could inform an Ontario mobile lung cancer screening program. So one of the things that we were thinking, if we are looking at a flexible deployment where the trailer actually moves to different sites frequently, is that Ontario is a really big province and there is significant weather that might affect where the trailer could go at certain times of year. So one of the proposals we came up with is that a mobile program could operate in the north, for example, during June to September, and in the south from October until May. This, of course, brings up the question of, is that helpful for people who need screening? So in the Ontario pilot, about 82% of people who came through the screening program had a LungRADS 1 or 2 score, which means they only needed annual follow-up. So those people could come back when the trailer came back once a year, and they would have appropriate follow-up with that. And in the BC pilot, they had 83% of their people on 1 or 2 year recall. So it's only a very small proportion of people who would need either a 3-month recall or a rapid workup. And I think that that's noteworthy because although that does mean that there would have to be some considerations of how do we continue to refer on the people who need a more rapid workup. Would the trailer come back, or would they be referred on to a hospital or a hub site? It wouldn't represent the bulk of the people who are getting screening. So it's feasible to think about a trailer coming to a community, for example, once a year and serving the majority of the population. The other thing that I wanted to point out was that from some of the learnings in Australia, we saw that when a trailer goes to remote communities, there is significant turnaround pressure for how fast data is processed. Because if, for example, a patient gets a scan and their lungs are clear, but there is a kidney lesion, and it would be fantastic to do a follow-up scan with contrast to really make sure that that lesion is appropriately worked up, then that needs to be interpreted and sent back to the team on the bus so that the patient can be brought back and have a second contrast scan before the bus leaves. So there are considerations about how long would a bus stay, how do you keep in touch with the people who have come onto the bus, do you do follow-up scans in the moment, and so on and so forth, that need to be thought about when developing a program, especially if the bus is only going to be in an area once a year. So these are some of the things that we've thought about when we were thinking about how do you design this program that can be flexible across Ontario. With that, I'm going to go ahead and pass it over to Stephen to talk about some of our feasibility findings.
Okay, thank you, Christopher. And as a reminder, I just want to mention that there are 3 reports on the Lung Health Foundation's website, so I encourage you to take a look at them. And, you know, really the top line finding indicates that it is feasible to implement, you know, a mobile lung cancer screening program. Really, should it be complementary to and integrated into the Ontario existing program? So Ontario has a validated, effective, and organized lung cancer screening program. There's established pathways, protocols, and infrastructure that all really allows it to be integrated into the existing program. Mobile trailer lung cancer screening equipment exists already, and it does meet the requirements for it. So nothing new needs to really be invented here. And a decentralized mobile lung cancer screening programs exist in other countries. So it does not require, you know, to be successful only in high density populations. So that's a really key piece for it, because especially in, you know, Northern Ontario, the density of the population isn't that big, but having, you know, when you consider different deployment models, then we can kind of adjust for it. And a mobile trailer lung cancer screening program could reach people experiencing significant barriers, and people have really stated a need for this mobile program. And I just wanted to quickly mention, it's been touched on at various times here, but there are multiple mobile services in other areas that exist, such as the breast, colon, and cervical units, dental, vision, harm reduction, psychotherapy, mobile services. They all exist, and these can be in the tractor trailer, truck, coaches, converted medical sprinter vans. And I just want to mention too, Teresa mentioned a lot about public-private partnerships, and they do exist in Ontario. For example, there are units that have been donated by various organizations, and the operating budget comes from the provincial government. Another key factor to consider is that mobile services, the areas exist where a hospital or an IHF-based service may also exist already. So IHF being independent health facilities, or they were formerly called. And so as an example, in Northwest Ontario, for the Screening for Life, their general goal is to go to communities where there are no breast screening pilot sites. So really, it's kind of a geographic focus. But they do spend a fair amount of time in Thunder Bay as well. And if you look at the Hamilton, Niagara, Haldeman Brant region, their focus is a little bit different. They're on trying to really reach communities in need. So the people experiencing high barriers to access. And with them, they could be in a community where there is a breast screening program there, or one of the IHF sites. And as has been mentioned already, there are some people that just may prefer not to use a hospital. In fact, there have been feedback from various mobile services that if the service was stopped, people may stop using the screening service. And so this is not just about convenience for people. So while we believe it is very feasible, there would obviously be a lot of complexities to implementing a decentralized model. And if we look at some of the various areas, so program design details, so obviously considering about staffing, scheduling, operations, technical requirements, these all become even more complex when you're looking at a mobile decentralized model. Obviously, a significant amount of work in the area of building up the community networks for collaborations and partnerships, funding for capital purchases and operations and evaluation and post-appointment monitoring processes. All of these things need to be considered and are all kind of real important challenging design details. The second main area is around system pressure points. And so limited access to primary care providers is a big piece, although there's an element of self-referral that is possible within the program. Having a GP or a nurse practitioner refer is, really a key point. And although there's low primary care access is widespread across the province, the reality is that racialized individuals and those of low socioeconomic status are less likely to have access and may be impacted more by the inability to get a referral. Another important system pressure point is around actionable incidental findings. And so this basically is just if a scan is done, but something else is found. Maybe there's cardiovascular issues, maybe the patient might have COPD. These are all things that need to be followed up with. And so in the Ontario pilot, about 20.5% of scans at baseline and around 10% at annual follow-up had AIFs, or actionable incidental findings. So it makes it really, really important to be able to assign a patient a GP or NP, not just for the referral, but because of some of the follow-up action that may be required. And of course, this will just increase, demand for follow-ups. And you also have to think of downstream activities. The lung diagnostic assessment program, biopsies and pathology reports, there's already pressures there. So there definitely are some system pressure points that need to be considered. And then a third one, just around mobile CT services. This may be unique in Ontario, but there currently is no legislation for a mobile CT, but we believe that there are pathways to move this forward. So those are some real challenges that exist, but we believe that they can all be overcome. And just in talking with Melissa Wheeler, it was a great conversation, and she just mentioned about humanizing the process. And we really have to remember that there are a lot of important details. They're difficult discussions and maybe hard to find the solutions out there, but it really is worth the effort. And we know the benefit of screening with a low dose CT is that it reduces the chance of dying from lung cancer, because it can find lung cancer at earlier stages when treatment has a better chance of working. And so finally, I just want to say that there has been great interest in a mobile trailer program. In all the engagement activities that we've had, the interest has been very positive. And I think the interest really grew when people started thinking about a mobile unit as adding capacity, the ability to work in kind of a hub and spoke model. At times it could be sitting beside the hospital, as we mentioned earlier, to offset some of the capacity. It could also go out into the communities to reach people that have difficulty in accessing it. So it is a real advantageous that it's able to be integrated into the hub and spoke model that's getting rolled out in Ontario. But basically, the project partners, the recommendations that we're putting forward for now is, one, we need to be able to establish a public-private partnership funding. And so Teresa had mentioned, 2-3 year pilot in Alberta, similar kind of thing. One of the real learnings was if you can get some funding for even up, 3 to 5 year pilot, where you can get the deeper insights, you can get the capital costs and the operating costs, you can really focus all your efforts on making the program successful, developing all the community networks and partnerships, rather than worrying about, kind of an annual, where's the funding coming from. So the second obvious recommendation is to collaborate with Ontario Health and the Ontario Lung Cancer Screening Team. We're certainly not proposing that this is a standalone program, but rather it needs to be integrated into the existing pathways and protocols. Thirdly, it's really to build a coalition of stakeholders to take lung cancer screening across the finish line. And what we're referring to here is really finding the right people who can help identify solutions to some of the challenges that I just previously mentioned. It will take a lot of effort to do that, and bringing those stakeholders together will be really key. Fourthly, again, mentioning about a nothing about us without us approach, requires further engagement with those who live in rural, remote areas, our low income, racialized people, our First Nations, Inuit, Métis, or urban Indigenous people. That will still and always be an important element in making kind of a co-designed program to be very successful. And finally, there are a number of patient, physician, and system barriers that need to be addressed. So we have to, the fifth recommendation is just addressing the equitable access challenges to lung cancer screening. And so with that said, we really believe that the work that's happened over the past years with the insights and the recommendations, these are all essential to making strides towards realizing a mobile trailer lung cancer screening program here in Ontario. And so that is everything, and I'll pass it back to you, Lisa.
Thank you, Stephen and Christopher and Teresa. Those were some really great reflections that you provided for us, very thoughtful and comprehensive reflections. Right now, we have a few minutes for panel discussion about some of the things that you were talking about implementing a mobile lung screening program. I'm just going to take one of the questions that came out. This came about during your presentation, Teresa, but I think all of you guys could probably answer this. It's amazing to see reflections on criteria to find the right partner in terms of mobile delivery. It can often be challenging to find someone that fits all aspects of the mold. Do you have any recommendations or tips for how to navigate partnership development, and in terms about actively searching for and finding partners on the ground that can really facilitate and assist rollout in remote communities. And do you have any lessons learned or advice for how to build out that network, in particular fostering trust?
I can start and then have others add, and always happy for that anonymous attendee if they ever want to reach out and actually have like a deep dive conversation. I mean, I'm actually going to go pretty high level. Like, I think it's always very important to understand what the priorities are of different partners and different communities. Sorry, my little baby just woke up. I think the other thing is so coming from a space of learning, I think that another area that's very important is a lens of humility. Like, the solutions we have may not be the solutions that actually they feel are the most important, but how can you add some level of value or meet them or acknowledge that? I think is important. I'm sorry. I think thirdly, you actually just have to start somewhere. I think that it's important to build depth in your relationships. Like, you don't want to come at just a shallow kind of space around it. I might have to just mute and let someone else grab the rest of the answer. But really build out depth within those. So you start somewhere, you add value, and you genuinely show your willingness to find kind of areas to start and add value. And then lastly is work with groups or communities where they're actually willing to champion your work. So start where there's readiness, which is why it wasn't just needs assessment. It's you have to meet communities where they're actually ready, and you can start there, and that will help your momentum. I'm so sorry.
Yeah, just to echo on Teresa's comments, for sure, desire and readiness are two really, really important factors. If that organization or community is very interested, but they're not ready to do it, the delays can be very costly, and it can be, a real negative effect, I guess, on the entire team that's working on a project. So to be able to have that organization or community of people that are really ready and able to participate, those are probably the two most important factors, I feel.
Great. And we have a question. All presentations identified private funding. However, shouldn't the $32 billion tobacco payout be considered for this? I didn't know it was a $32 billion payout, but good to know that it's there. I don't know if has anybody tapped into it or knows how to tap into it.
Yeah, no, it's a great question. And while yes, we have talked a lot about private funding, I think the reality is that, and Melissa mentioned this, that you're probably not going to find one organization or one entity that's willing to, cut the check to do an entire program and pilot it for 5 years. So we're going to have to reach out to multiple organizations, whether it's public, whether it's private. And certainly we could buy a couple of trailers with that 32 billion. So it would be definitely something to follow up on.
And then finally, we have a comment in the chat. This was a great panel discussion. I know primary care constraints were identified as a barrier to moving forward with this, but perhaps mobile lung cancer screening could play a pivotal role in alleviating the primary care shortage by streamlining the referral process and reducing the burden on primary care providers. With a physician delegate attached to the mobile coach, individuals could undergo a risk assessment on site, and if deemed eligible, be directly referred into the screening program at a thoracic center or via the coach without needing an additional primary care visit. This approach not only improves access to screening for high-risk individuals, but also optimizes healthcare resources, allowing primary care providers to focus on other patient needs. Integrating this model could be a valuable strategy to expand lung cancer screening while addressing Ontario's current primary care challenges. And of course, we have that already in existence with the Ontario Breast Screening Program, where patients self-identify and can self-refer to breast cancer screening, starting from the age of 40 and on. So I think that's a great suggestion that yes, that people could self-refer, and there could be delegates there who do who can address and do those assessments. I think that's a great idea. So we're at the end of this very interesting policy forum that we had this afternoon. There's still lots of obviously conversations that need to be had. And I'm just gonna say thank you very much to everybody for allowing me to be part of this day. And I'm gonna pass it off to Jessica Buckley.
Thank you very much, Lisa. Just a couple of comments. Thank you, Jessica, for posting that suggestion in the chat. That was very helpful. And just the comment about the tobacco settlement. So it is a proposed settlement at the moment, but the Lung Health Foundation and some of our partners are very committed to ensuring that some of that settlement does go toward programs and prevention and potentially programs like screening. So it's a great call out and suggestion, and we're going to be meeting with levels of government to have those conversations. So today has been a fantastic afternoon. Thank you for taking all the time to spend with us. It's been a great couple of hours. The speakers have been fantastic. We do have a call to action to ask of you, and you've taken the time to come here and learn more. We would like to ask you to help us create the political will. So we saw from, Alberta and the presentation by Teresa that when there is the right political will and the right partners that come to the table, these solutions can come together and be implemented quickly. So we are trying to create that political will, and we're asking that you sign a letter of support on our website. So the page is posted, and there's also a QR code here that you can scan and become a signatory to our letter of support. And please fill in pertinent information, your name, email, province, and how you connect to this, whether you're an oncologist, a researcher, a caregiver, an advocate, etc. So we'd like to send a powerful message to our government partners and work together with them to help bring this. Lisa Jackson made a comment earlier that really resonated with me, talking about communities not as underserved, but communities as being undervalued. So that is a very powerful distinction. Again, I'd like to thank our speakers, Lisa, Stephen, Christopher, Lisa Jackson, Teresa, Laura, and Melissa, who joined us remotely. Thank you so much. Our sponsors, again, we had Amgen, AstraZeneca, Bristol Myers Squibb, Gilead, Janssen, Merck, Pfizer, and Roche. Thank you for supporting today. And our hope from today is that legislators and policymakers that are listening here or potentially to the recording of this are going to be able to take away actionable steps in helping make lung cancer screening more accessible for everyone. And the Lung Health Foundation is committed to posting this policy forum on our website, so you'll be able to receive a notification once it's available to share with your networks. We would like you to take the moment to complete an evaluation form if you would, because it helps us improve these policy forums and how we format them for the future. Also, we're going to summarize today's key discussion points and send that out as well for our ongoing advocacy and improving access and execution of lung cancer screening across the country. So we do have 2 more policy forums taking place in this Breathe Change series. Our next policy forum is coming up December 4th. And that one is going to be related to lung cancer in that it's focused on understanding Canada's radon gas exposure crisis and where we are, having had the Evictoradion report come out just in the last 2 weeks. So we posted the link in the chat to register for the next forum for December 4th. We hope that you'll share that with your colleagues and friends. And once again, thank you for joining us today. We really appreciate your time and hope to see you in December.